位专家的支持以及上线。那我们本次会议即将开始，首先邀请我们邱教授来开始主持我们本场会议。那邱教授，您准备好了吗？
OK，谢谢大家，晚上好啊。非常荣幸能够在这次叫
Okay, good evening, everyone. So it's my great honor to attend the MDT session and also to meet all of you. I understand right now in the US it is the morning time. So good morning, everyone. So I think for intensive infection, it is a very critical clinical issue for all of us. I understand this is also a global issue. Everyone pays a lot of attention to it. So I think for today's meeting, we hope that with the multidisciplinary discussions, with the discussion of the experts in the two countries, we can have the joint explorations of the new solutions for the intensive infection. So I think for a new medicine, namely ceftobiprole, I want to underscore this medicine to you. This is the fifth generation cephalosporin, and originally it was developed by a Switzerland company. And nowadays, the China Resources introduced it to China, compared with the first generation or the fourth generation. Actually, for ceftobiprole, it has higher potency in the treatment and inhibition of the gram-positive bacteria. And you may also learn that there's a study published in 2023's New England Journal of Medicine comparing ceftobiprole versus datomycin. And this study proves its inferiority to datomycin. And nowadays, it is also included in the national reimbursement list. So I want to give you this information. And so for tonight's session, we have two cases from our international experts. We also have a domestic case from the Huashan Hospital. So firstly, I'd like to give the floor to the two chairpersons to give us the opening remarks. First, the chairperson is Professor Wang Minggui. He is the director of the Antibiotic Institute of Huashan Hospital, and we also know that he is the standing committee member of Chinese Medical Association of Infectious Disease Branch. So now I will hand over to Professor Minggui to give us the opening remarks. Thank you. Respected Professor Chiu, Professor Hen, and distinguished professors, it's my great honor and pleasure to meet all of you and also to have the MD discussions of those cases. Well, I attended another similar meeting, and we think the MDT is the right way to go forward for our learning. And I also learned from the prior sessions that the translation has been done in a very good manner. And because for many diseases, we can share with each other as how to treat the infections, but we also know that we have different habits of utilizing the medicines. We also have different preferences and different medicine accessibility and affordability issue. And for the last session, we have go beyond our schedule, and we had a very in-depth discussions for the last session. And also for today's meeting, we also had sessions designated for the discussion. So I hope that for tonight's meeting, you can have some important takeaways. Thank you very much. Thank you, Professor Wang, for your kind opening remarks. So our second chairman is from Duke University Medical Center. Professor Vance Blower, and he also has many important academic titles. He is the MD of the medicine and molecular genetics and microbiology. And also, he is a renowned professor of medicine. He has a lot of experiences. And also, he is PI of the NIH. And for HI index, I think this is very astonishing. We see few professors that can have H index more than 100. It means that he is indeed a top expert in this field. So I do have high expectation for tonight's discussion. So Professor Vance, over to you.
Thank you for this opportunity, and very excited to discuss methicillin-resistant Staph aureus and difficult cases in this disease. Thank you.
好的，好，谢谢。
Thank you. Thank you, Professor Vance. And we will continue with our first case. So the first case is from Professor Thomas Holland from Duke University Medical Center. He's going to share with us a case of MRSA with cardiac implants. So this is the brief introduction of Professor Thomas Holland. And so we can see he is a professor of infectious disease. He is also PI of multiple studies and trials. He is also involved in the assessment of the double vaccine in the treatment of the complicated S. aureus bacteremia. He is also the PI of the phase 3 study of the cefalopropyl. And so I think his case is going to be very inspirational to all of us. So over to you, Professor Thomas.
Wonderful. Thank you so much. I appreciate the opportunity to be here. Let me get my screen shared correctly here. Great. So this is a case of a cardiac device infection. And as Dr. Fowler had said, the way I've arranged this presentation is that I'll show some highlights of the case and then pause for some discussion along the way. Hopefully that way of presenting works for everyone. My disclosures are listed on this slide. So the case that I'll share with you is a case of a 64-year-old male who presented to the hospital with approximately 3 weeks of difficulty breathing, had nausea, had vomiting. His medical history is notable for the presence of a dual chamber pacemaker. And then importantly, he had a previous history of MRSA bacteremia around the time that pacemaker was implanted or was placed. That was approximately a year prior to presentation. He had been treated with vancomycin at that time and now has been off all antibiotics for the past 9 months. He's on some medications, but these are not contributory to the case. So when he's first seen, his vital signs are listed here. He had a temperature of 37.9 degrees Celsius. His heart rate was a little bit fast at 104, blood pressure of 104/60. There was not an identifiable source of infection on his exam, but he was noted to have a cardiac murmur, rated 3 out of 6, holosystolic murmur at the apex radiating to his axilla. And then physical exam was also notable for infarcts on the fingers of his left hand, as pictured here. Additional laboratory and imaging data are given here. He had an elevated white blood cell count at 15.7 thousand with approximately 12% bands or immature forms. So that's an elevated white blood cell count. He had evidence of a kidney injury with a creatinine of 2.1, which is elevated. Normal would be closer to 1. His chest x-ray did not show pulmonary edema, and an electrocardiogram did not show heart block. He had an echocardiogram performed, and that study showed that he had moderate to severe mitral regurgitation. There were no cardiac vegetations or valvular vegetation seen on that study, although it was notable that it was difficult to obtain optimal views because of the patient's obesity. So as I think we would all do in a case like this, the first thing to do is to start antibiotics and to start fluids, since he was relatively hypotensive as well. So he was started empirically initially on 2 antibiotics, on vancomycin and piperacillin tazobactam in our emergency department. Blood cultures were obtained at the time of presentation prior to antibiotics. And these blood cultures within the day grew Staph aureus, which was MEK positive by PCR. So I'll pause there and ask if there are any other diagnostic tests that the panel would want.
Well, Tom, I think I'll start off just to give everyone a chance to familiarize themselves with the format today. But I'm worried. I'm worried about some sort of endovascular source of infection. You have an individual who has an endovascular cardiac device, who has Staph aureus bacteremia with a prior history of MRSA bacteremia, without an identifiable focus of infection, and with the presence of evidence for embolic phenomenon. And so even looking at the criteria like Nolan and Beatty's paper from the 1970s that identified, the presence of endocarditis in absence of a primary source, presence of embolic phenomenon, and cardiac evidence of cardiac device, I'd be highly worried for the presence of endovascular infection, particularly endocarditis, and I personally would be pushing for a transesophageal echocardiogram. And I'll stop there. Thank you.
Great. Thanks, Vance. So, I think I agree that that's right. There are probably a couple of imaging options, and these may vary by availability and by cost, depending on where you're practicing. Transesophageal echocardiography, as you mentioned, Dr. Fowler, would be our first imaging modality of choice. There is increasing evidence or use of PET-CT, and as part of European endocarditis guidelines as well, and part of the updated Duke criteria for diagnosis of endocarditis. I'll make that comment. This is work that has been done for many years. This is dating back all the way into the 1980s. That if the more echocardiography that you perform, both transthoracic and transesophageal echocardiography, the more endocarditis cases you will find. So in this graph, the clinical suspicion for endocarditis among patients who have Staph aureus bacteremia may be relatively low, or at less than 5%. But when imaging is performed, TTE and especially TEE, an additional cases will be found of endocarditis in upwards of 20 to 25% of patients. We've thought about this, whether every patient who has Staph aureus bacteremia should have a transesophageal echocardiogram. We had performed a review, you and I, as well as one other author, approximately 10 years ago. There has not been a trial that randomized patients to different echocardiography strategies. So this data is based on observational studies. And in these studies, there are variable rates of performing transesophageal echocardiography, and that's not a random decision. Often physicians or providers will be pursuing echocardiography in patients where they have a higher suspicion of endocarditis, like the case that we're talking about now. But what was clear across all of these studies is that if there are more transesophageal echocardiographies done, there will be more diagnoses of endocarditis made. There's still some things that we don't know. If there are patients who, for example, if there are patients where endocarditis is detectable only by transesophageal echo, meaning that you can't see it on a transthoracic echo, but only on transesophageal, do those patients have the same outcomes, the same natural history as patients where you could see a vegetation on a transthoracic echo? And then, of course, like as in so many areas, this technology, the echocardiography technology, is not staying the same. So it's improving all the time. So transthoracic echocardiograms today are better than they were 10 years ago or 20 years ago. And there's also always the question that if you have a patient that you're planning to treat for a long time for infection at another source, for example, a bone infection, vertebral osteomyelitis, then you may not gain as much by doing the procedure, by doing a transesophageal echocardiogram, at least as it relates to duration of therapy. One way that in order to make this decision around whether or not to get a transesophageal echocardiogram, there have been a number of scoring systems that have been developed as a way to predict who will have endocarditis on a transesophageal echocardiogram. The VERSTA score shown here is the score that has performed best out of these scores that have been developed. This was developed from a cohort of adults in France, in a cohort where the endocarditis rate was approximately 11%, meaning 11% of patients with Staph aureus bacteremia were diagnosed with endocarditis. And this score takes a number of risk factors listed in this table and assigns a weight to them. And then that aggregate score can help predict the risk of endocarditis. And depending on how many points a patient has on that VERSTA score, there is a trade-off or test characteristics comparing sensitivity and specificity. And if you use a cutoff of 3 or more points as compared to less than 3 points or 2 or fewer points, then this score has a good sensitivity of about 96% with a reasonable specificity as well. And so one way to think about this would be to apply the VERSTA score, which in our patient's case, as Dr. Fowler has pointed out, we're already seeing, in this case, embolic physical exam findings in the hands, which would give a weight or enough points here that we would want to pursue a transesophageal echo for this patient. PET CT I've mentioned as well. It's emerged as an option. It is included as a major criterion in the 2023 Duke ISCVID endocarditis diagnostic criteria. There's observational data that supports the use of this imaging modality as well. I think the best of this data was a study that was performed in Israel, published in Clinical Infectious Diseases in 2020. And in this study, this was a cohort that was matched where PET-CT was performed 1 to 2 weeks or 7 to 14 days after the onset of Staph aureus bacteremia, where there were 124 patients consented to undergo this imaging study. In addition, there were 25 more patients who had the study performed as part of their usual care. And these patients were matched to similar patients with Staph aureus bacteremia who did not have a PET-CT performed. And similar to the data around transesophageal echocardiography, one thing that we learned is that PET-CT can help find additional sites of infection. So to orient to this table, the clinicians caring for these patients were asked what sites did they think were infected with Staph aureus before they obtained a PET-CT. And as shown in the red box here, there were a number of different anatomic sites ranging from bone and joint to skin to cardiac to lungs and others as listed here. So these were the sites that the providers thought were infected. When they actually obtained the PET-CT here in the blue box, some of those were confirmed. Some of those sites that they suspected were actually confirmed to be infected on the imaging study, and then some did not appear infected. So some were excluded, some were confirmed. And then importantly, in the green box, there were a number of sites that were newly diagnosed. So these were sites where the clinicians did not suspect that there was infection, but infection was found, or areas that lit up and appeared infected on the PET-CT. And these ranged across all sorts of anatomic sites. Again, bone and joint, skin, vascular, cardiac, lung, all of the different sources listed here. And so in total, there was a site of infection in over 70% of the patients when a PET-CT was done. And the majority of these, 67%, were new diagnoses. These two groups were managed differently by the clinicians. The patients who had a PET-CT performed ended up having more other interventions, more TEEs, more source control procedures, and they were treated for a longer duration, a median of 42 days compared to 19 days. And as a result, or in the end, the mortality in the group that underwent or received a PET scan was lower than in patients who did not, 13.9% versus 28.5%. And as you can see, there are a lot of things that are different about these groups. It's not just that there was a PET-CT, but the management was different as well. One caution has been raised by some collaborators, including Thomas van der Vaart, who have noticed that there is a concern around immortal time bias in an observational study like this, meaning that patients had to survive long enough to have the PET scan performed. And so this may account for some of that mortality difference that's observed in studies with this kind of design. So at least in my practice, PET-CT is emerging as a new option. The cases where I tend to use it most are patients who I think are high risk for a deep-seated or a metastatic infection, but I can't find it. The focus is unknown after an echo, like Dr. Fowler suggested, and after imaging directed at any symptoms. If the patient has back pain, we would image the spine. If the patient has hip pain, image the hip, for example. And I would especially be worried about patients whose blood cultures continue to be positive, who have persistent bacteremia, and we don't know the source. It can also be very helpful when it will influence surgical management. For example, if a patient has a dialysis graft in the arm and we're not sure if that graft is a source of infection or not, then a PET scan may help us understand and collaborate with the surgeons to remove that graft if it does appear infected on a PET scan. And I would also point out that we will, before too long, have the benefit of some additional trial data on this. So there are at least 2 trials, randomized trials that I am aware of that are looking at PET-CT. One called TEPSTAR, where the primary endpoint is whether PET-CT will find more infectious foci. And then the large SNAP, Staph aureus Network Adaptive Platform being run from Australia, but a worldwide platform that is enrolling an arm where PET-CTs are performed somewhere between day 7 and day 12 of bacteremia, with the primary outcome of 90-day mortality. So this will be really useful to understand if obtaining PET-CTs in all patients with Staph aureus bacteremia is associated with a mortality improvement.
Tom, this is Vance here. Any thoughts or evidence about using a PET-CT or a negative result from a PET-CT to justify shortening the course of therapy, such as as was seen in the 2020 paper that you showed from Israel?
Yeah, meaning that those patients who had negative PET-CTs in that group were treated for could be safely treated for a shorter period of time. Is that would be the idea?
That's the thought. Is there any evidence that would suggest that could be an effective strategy in certain circumstances for patients with MRSA bacteremia?
Yeah, I think you may know, and I suspect you do know the data more than I do. That data certainly exists for transesophageal echocardiography, right? So patients who have a negative TEE and then have other, clear their bacteremia, don't have other sources evident. We know that we can treat those patients safely for shorter courses. I'm not aware of equivalent data in that 2020 study for PET-CT. That duration of 19 compared to 42 days, that's comparing patients who did not have a PET or did have a PET, as opposed to the triaging by the result of the PET scan. I think we know that I would be more reassured by a PET scan that was negative, but I guess I'm not aware of data specifically using PET scan to determine duration of therapy, and I'll be glad to hear if you know of that.
No, I think that's largely right, and I think there's been some work from the Netherlands suggesting that it may be a way to abbreviate courses of therapy, but I think it may be an option in limited circumstances, in particular individual cases, but in general, we still need to use basic clinical judgment, I think, as determining things like duration of therapy.
Yeah, thank you.
And I have a question for the cost of PET-CT in the US. In China, it's relatively expensive, cost about 1,000 for the examination. So, what's the cost in the US?
And you mean for the cost for a PET scan specifically?
Yeah.
Yeah. No, we have the same issue. Actually, PET scans at our hospital are difficult to get, just from an availability standpoint. It really takes some work to convince the radiologist to perform the scan, and then it is expensive as well. And so I would expect that study would cost several $1,000s for us as well.
Okay. Is it covered by insurance?
Yeah, typically, for patients in the hospital, it would typically be covered by insurance. Often the way the payment is made, it's paid, insurance pays based on the reimburses on the hospitalization. And so the individual studies that are done during the hospital stay are usually not charged to the patient individually.
Professor Chu, do you have?
Yeah, 我想问你个问题，我是觉得
I have a question. So I listened to Professor Holland's talk. So after the PET-CT, if the result is negative, maybe we can shorten the treatment duration. But for acute endocarditis, with or without PET-CT, the treatment duration cannot be shortened. But the good thing about PET-CT is that maybe we can identify remote infection focal or the lesion. So my question for Professor Thomas is that, so how many patients that have the acute endocarditis, or how many of the patients that have the distant infection that I need to do extra treatment?
Yeah, it's a good question. So, PET may help diagnose endocarditis specifically. So you may see a cardiac valve that that lights up on PET scan or is abnormal on PET scan. The rate of finding other sources is probably, that Israel study is among the best for giving us an estimate of how common that would be. And again, it's in a majority of patients. So I think that if you perform a PET scan in every patient with endocarditis, you would likely find additional sources. I think some of those sources will be evident based on your history and your physical exam already. And so it's not, at least in part of my practice, to perform a PET scan if I have a diagnosis of endocarditis and feel comfortable with the treatment course that I'm performing. So that would not be a scenario where at least I'm commonly additionally getting a PET scan.
Thank you. I also echo with you. I have another question. For
Sure.
example, so for your
for this patient with vegetation, I don't, because this patient has a pacemaker, so the bacteria should be from should be the catheter related, should be the related. I don't think it's from for other location. So for this patient, the pathogen is not necessary. Maybe for this patient, what's your opinion? Just at this point, at this.
Yes. So, in this case, just to, and I'll continue with the parts that are on this slide. So he did undergo the transesophageal echocardiogram, where there was a vegetation seen both on his pacemaker lead and on his mitral valve on the other side, with severe mitral regurgitation. And so, I think that you're right. So we would not necessarily need to be looking elsewhere for a source of infection. This gives us a good rationale for why this patient is ill and likely for what needs to happen next. So at this point, the patient is on vancomycin monotherapy, being dosed by area under the curve. But the blood cultures in these first days have not cleared. So as we approach a week of therapy, the blood cultures are still positive. So we've been talking about imaging and about ways to look for other sites of infection. It's probably clear to this audience, but what else do we need to do therapeutically at this point? And I think that is likely relatively evident that this is an indication for removal of his cardiac device. So MRSA, infection of a cardiac device, is an indication for device removal. And in this case, he proceeded to surgery both for cardiac device removal and, given the severe valvular dysfunction on the mitral valve, had a mitral valve replacement as well. And so then I'll ask our panel, or our professors as well, when in your practice would you consider it safe to replace his cardiac device if he needs his pacemaker? If he's pacemaker dependent, when is it safe to replace that? And what kind of device would be utilized in your practice?
I can take that one.
我想
Um,
sorry.
go ahead. Please
Sorry.
go ahead.
I just introduced some professor, the expert, yeah. 因为我们这里所有讨论的嘉宾，除了
So
这个
because we do have domestic Chinese experts join us for the panel discussion. So we have Professor Huang Yan from Huashan Hospital. Professor Huang is expert in infectious disease. We're also very happy to have Professor Pantren from the critical ill disease department. We also have Professor Morit join us for the panel discussion. So if any questions you have, so please raise them up.
Okay, great. Dr. Murad, you were going to weigh in.
Okay, Professor. I think for the how to say the antibiotics agents for me, for example, the vancomycin is not works very well. Maybe I want to try daptomycin, but you know the mitral valve is also have the vegetation, and we also know that the daptomycin is not works very well on the left heart endocarditis. But I don't know how to choose. And what's your opinion for
Yeah.
this? Yeah.
Well, it's a good question. You know, I think the probably first principle here is that there's probably no antibiotic combination that will be effective until the source is addressed, until the infected cardiac device is removed. And in this case, the mitral valve is operated on as well. So, you know, one thing I would not do is change to daptomycin before those things are done, meaning that, you know, both in Dr. Fowler's original daptomycin trial that led to its FDA approval, as well as in our ceftobiprole trial, patients who are on daptomycin and then fail therapy, they tend to fail with antibiotic resistance. And so I think if we switch just from vancomycin to daptomycin in this scenario without taking out the cardiac device, without addressing the mitral valve, then we would likely, that's a situation where there would be a risk that the patient would develop daptomycin resistance on therapy and would you know, fail treatment. So I think that the primary thing to do here is to achieve source control. And then probably the antibiotic choice is secondary to that. I'm aware that I'm close on time, so I'll please, if there are other questions, and otherwise I'll presentation.
我来稍微补充一句话，因为我们
So I have an extra comment for the MRSA bacteremia. So so for vancomycin or daptomycin, if the bacteremia can last for more than 48 hours or last more than 48 hours, so the treatment failure probability would be increased. So I think for this patient right now, the situation is very critical.
I agree. Yeah, thank you.
Yeah.
So for this patient, I'm going to pass through this. You know, one thing that's of interest, and I'm curious if you're starting to see these devices used in China as well. One option to replace the device, so we would ideally want to wait both until the patient had cleared his blood cultures post-operatively, and because there was a valvular vegetation, ideally for at least 2 weeks of therapy prior to replacing the device. There's an increasing trend in the United States to use these leadless intracardiac transcatheter pacing systems. These were first reported almost 10 years ago in the New England Journal in 2016 as devices that can successfully be implanted and meet their pacing threshold. Initially, when these leadless, the advantage is there's no lead where infections often can be found. at least in the initial studies of this device, there were no infections that were seen during the follow-up period. I first saw one in my own practice, a patient who had one of these leadless, they're quite small cardiac devices, who did have an MRSA infection of that cardiac device with the vegetation there that persisted until it was removed. We took the opportunity, Dr. Murad and Dr. Fowler and I, along with Dr. Niehaus here, to look at the literature, and what we can see with these leadless pacemakers is that infections can happen. Like any endovascular prosthetic material, it can get infected, although these are quite rare and do appear to be more rare than what we see in conventional pacemaker devices. So it's our feeling, at least, that at a minimum, we would delay the implantation of this sort of device until after the patient had cleared blood cultures. And as is probably all of our clinical experience, the most common pathogens that will cause trouble with these devices, the most common pathogen is Staph aureus, both MRSA and MSSA. So the end of my case here, this patient's bacteremia, his blood cultures did clear promptly after surgery, had a leadless pacemaker placed approximately 2 weeks later, was treated initially with vancomycin while in the hospital, and then as others were mentioning before, he was transitioned to daptomycin, again, not as a way to rescue failure or because of persistent cultures, but because it's simply easier to administer and dose. Daptomycin being dosed once a day is easier for patients who are completing their antibiotic course outside of the hospital. And so that was selected for him for the end of his therapy. When last seen a year later, he was doing well after that infection episode. So I'll stop there. I'm conscious of the time, but happy to entertain any comments or discussion that anyone has.
好，各位专家，
Okay, Professor.
Any questions?
You change the antibiotics to the daptomycin, and what dose you choose for this patient?
Oh, that's a very good question. The FDA approved dose for us is 6 milligrams per kilogram, but for Staph aureus bacteremia, I would typically use a higher dose of at least 8 to 10 milligrams per kilogram of daptomycin. So outcomes, at least in observational studies, appear better with the higher dose daptomycin. We were hoping to learn about this in the ceftobiprole trial we did as well, where ceftobiprole was compared to daptomycin, and there could be some variation in daptomycin dose. Unfortunately, from the standpoint of dosing, almost all of the patients in that trial received the 6 milligram per kilogram dose. There were not enough patients that received higher doses to really have a randomized comparison there. But it's my practice to use at least 8 and commonly 10 milligrams per kilogram for patients with Staph aureus bacteremia and endocarditis. Great, thanks. I'll stop sharing my screen.
好，谢谢 Professor Thomas Holland.
Thank you, Professor Thomas Holland. A very wonderful case. So I think the way we go through this case is very good, because Professor Vance also gave us many important comments during the presentation, and Professor Minggui gave us very good question and a comment during the presentation. So I think we are pretty much done for the first case.
I'd like to ask one question to Professor Holland. You've just mentioned about the patient being switched from vancomycin to daptomycin. In my impression, I think for muscle-induced bloodstream infection or endocarditis, daptomycin seems to be the first choice. And for this patient, the patient transitioned to daptomycin after discharge. According to your practice, maybe it should be switched earlier. So why do you switch to daptomycin later?
Yeah, it's a good question. I do think that either antibiotic, either daptomycin or vancomycin, and then now that we have ceftobiprole approved, that would be a third option. I think any of those are reasonable options for treatment. And so I think daptomycin could have been utilized earlier. The only concern I have about early daptomycin use is I do worry about development of resistance on therapy in patients who don't have source control. So, I think daptomycin would be fine. I would want that cardiac device removed promptly and valve surgery done as well in order to feel most comfortable with daptomycin. But I think either one is okay. It could have been vancomycin or daptomycin. We often use vancomycin in the hospital. Primarily for cost reasons. It's more inexpensive for the institution. And because when we have patients in the hospital, that's a scenario where we can monitor vancomycin levels and optimize the dosing. But again, I think you're right. It could have, either one would have been a reasonable option earlier in the case.
Another question about the treatment course. So after surgery, the patient has already have no endocarditis, but patient still have vegetation, one from the pacemaker and the other from the mitral valve, on the mitral valve. And the patient received 6 weeks of treatment. If the patient is not so severe, if it's a milder patient, does not require surgery, then usually for this kind of milder cases, how long will you use daptomycin?
Yeah, so I would have treated for 6 weeks with or without valve surgery, I think is the short answer. So if the patient did not have severe mitral valve dysfunction, did not require mitral valve replacement, then I still would have treated for 6 weeks from the date when the blood cultures clear. So that first day that blood cultures do not grow Staph aureus would count that as day 1 of therapy and would treat for 6 weeks. Really, the only patients with Staph aureus bacteremia that I treat for short course meaning 2 weeks or 3 weeks, are those that are the least complicated. The patients who have a catheter infection where the catheter is removed and there's no other site, a TE is negative, everything goes well. Those patients are very unusual in my practice. Almost all of the patients I see with Staph aureus bacteremia have complicated disease, and I would say 6 weeks is a standard treatment duration.
Okay. 好，再次谢谢 Professor.
Once again, thank you very much, Professor Thomas Holland. I'm afraid in the interest of time, we have to move on to the next case.
Yep.
And the next case is also from United States, also from Duke University. Professor Murad. This is a case who have effective endocarditis because of injection drug use. Professor Murad, please. I'm not going to introduce Professor Murad. We have already introduced him before. Professor Murad, over to you.
All right, great. I'll share my screen here.
Yeah. Yeah, okay.
All right. Can you guys see?
Yes.
All right, great. All right, awesome. Well, thanks so much for having me. So yeah, we're going to talk about a case of endocarditis that is associated with a person who injects drugs, which is getting more and more common here in the United States. I don't have any relevant disclosures for this talk specifically, but here are my disclosures. All right, so for the interest of time, we'll just go quickly here in the initial presentation. So this is a 32-year-old female who comes into the hospital with 3 days of fevers, chills, just feels, just feeling terrible for a couple of days. She has ongoing injection drug use, uses heroin. Blood cultures are obtained. She's empirically started on antibiotics in the emergency room. Blood cultures quickly turn positive for MRSA, and she gets a transesophageal echo that shows a large 2.4 centimeter tricuspid valve vegetation with moderate tricuspid valve regurgitation. So her antibiotics are narrowed, and she's just on vancomycin monotherapy at this point. So just quickly touch on right-sided endocarditis. And please tell me if I need to talk slower for the interpretation. So the global incidence of endocarditis as a whole is, almost doubled, more than doubled in the past couple of years since the 1990s. Right-sided endocarditis accounts for up to 10% of cases of endocarditis, with injection drug use and cardiac devices being the biggest risk factors for having right-sided endocarditis. And 90% of endocarditis among those who use injection drugs is right-sided and involves the tricuspid valve. So exactly like we're seeing with this patient here. So going back to our case, like I said, the patient is on antibiotics. Blood cultures 48 hours after starting antibiotics are still positive for MRSA, so not unusual for somebody with an endovascular source. Persistently febrile, she develops new shortness of breath. She gets a CT chest, which shows multiple lesions, which suggest septic pulmonary emboli. Repeat blood cultures 96 hours after starting antibiotics are still positive. So you have a patient who is on the appropriate antibiotic, but has a persistent nidus of infection, has new embolic phenomenon, persistent fever, persistent positive blood culture. So what would the next steps be here? What would people be wanting to do?
For
this patient, I would like to comment. The patient may need a PET CT because we can see the patient already have septic pulmonary emboli. So if it's already absent embolic in the lung, there might be some emboli in other places as well. So patient may need a PET CT.
Okay.
What about the others? Professor Huang and Professor Wang. We also have Professor Zai, who will join the discussion as well. Feel free to comment. I agree with Professor Cho. The PET CT as a diagnosis of infective endocarditis. For me, I don't have much experience with PET CT. Today, hearing the two cases presented by our US colleagues, basically for us, we only use MRI, CT, or ultrasound to screen whether there's metastatic foci. For me, if my patient, my IE patient, doesn't respond to treatment well, they usually have metastatic emboli, etc., and abscess. If there is abscess, we need to do the drainage in a timely manner. For this patient, I think we need to focus on two things. The first one is to see whether there's some of the metastatic foci, and also maybe switch the medication, because for vancomycin, that might not be the best option for MRSA. We still have two other treatment options that may be more appropriate comparing to vancomycin.
Okay, so generally people, more imaging, and then maybe, talk about antibiotic switch, not necessarily maybe switch, but maybe considering things like combination therapy or other things. Would anybody consider procedural intervention here? Does this person need surgery for source control? What are your thoughts on that?
Yeah, Dr. Murad, this is Vance Fowler. That's sort of my question. It's always tough with these patients, of course, because placing a device in an individual with injection drug use puts them at very high risk of infections in the future. Nonetheless, if you fail to clear their bacteremia, then you're obviously not giving them best care. I would be worried about the need of the ongoing bacteremia, and I think I would be asking the potential options for what can be done for source control, having the cardiothoracic surgeons evaluate the patient.
All right, fantastic. So just wanted to cover, surgical indications for right-sided endocarditis. So the data is not as robust as with left-sided endocarditis, where we have good trials that have been done. But based on some of the consensus statements that we've seen from societies like the American Heart Association, the guideline-based surgical indications for valvular right-sided endocarditis are persistent bacteremia, difficult to treat pathogens, large vegetations that are more than 2 centimeters, recurrent emboli, so recurrent pulmonary emboli, heart failure, new heart block, or perivalvular abscess. So our patient has persistent bacteremia, has a large 2.4 centimeter vegetation, and recurrent pulmonary emboli. So this is somebody that we should consider for interventional, for a surgical or interventional option here. So we did consult cardiothoracic surgery on this patient, and as Dr. Fowler was alluding to, it's often difficult and challenging, and can sometimes be risky to place prosthetic devices or prosthetic valves in patients with ongoing injection drug use. And so the surgery team was concerned about that, and in their consult, they said that the patient would not be a surgical candidate for conventional surgical valve replacement due to risk of recurrent endocarditis. So there was a study in a large tertiary academic center in the United States that found that over 50% of patients who had endocarditis from injection drug use who undergo valve replacement presented with recurrent endocarditis in a median of 18 months. And so that is recurrent prosthetic valve endocarditis at that point. And then the short-term post-surgical mortality for these patients is high as well, and it's more than 10%. So there are, more acute concerns and more long-term concerns for these patients. So if conventional surgical valve replacement is not an option, is there any other intervention that can be done here? So I wanted to talk a little bit about something called percutaneous mechanical aspiration. It's a technique that is evolved over the past couple of years. We've been seeing it more and more in the United States, at least, and in Europe, being performed in patients who cannot undergo conventional valve surgery or replacement for endocarditis. This technology mostly stemmed initially from the cannulas and catheters that were designed for thrombectomy in pulmonary embolism, and then were evolved so that they could extract vegetations from or other masses intracardiac. And so this is a percutaneously inserted cannula that's used to aspirate the intravascular material. Angiodynamics is a company that makes a system called the AngioVac system, and it's a very frequently used percutaneous mechanical aspiration system. The AngioVac was initially approved by the FDA in 2009, and then the indication was expanded for intravascular and intracardiac thrombi and other materials more recently. So a little bit more about the AngioVac system itself. It is a closed system. So this is a representation from a publication that we recently published. And it is a closed system that uses extracorporeal circulation. You have a suction cannula that's placed into either the superior vena cava or the inferior vena cava, and then blood is circulated through these cannulas through a filter by a centrifugal pump. And then the suction cannula is advanced up until it gets to the valve and the vegetation, and then suction is applied through the centrifugal pump, and then the vegetation and the debris can be extracted in that way. So this is a case that was done here at Duke. This is the pre-procedural echocardiogram. So you can see here the large vegetation on the tricuspid valve, and the cannula was advanced, suction was applied, the vegetation was removed, and this is the post-procedural transesophageal echo. And then this is how the filter looks, which is over here, and this is the debris that was collected from the filter. There are other percutaneous mechanical aspiration systems that don't utilize extracorporeal circulation. There's the two that are most commonly used, but we've been seeing, and as we'll see now in the literature as well, it seems like angiovac is more favored for these procedures. So what do we really know about this procedure? You know, I've just described what it is and how it works in theory, but there are no clinical trials. There are very few cohort studies, but there are a lot of case reports about its use. And so we had that question, and we decided to do a scoping review of the literature to try and identify the characteristics of the patients who are undergoing these procedures and try to understand some of their outcomes. So we did a scoping review. We found 51 studies published in a 10-year time period with almost 300 participants that were included in our final review. Most of the studies were from the United States. The other studies that were not in the United States were from Europe, mostly Italy and Germany. And then most of the studies were case reports or case series. So we only had two cohort studies. So there aren't really any comparator groups used in these reports to really understand the outcomes better here. The majority identified, we identified the majority of articles that looked at percutaneous mechanical aspiration for valvular endocarditis, and then the others were used for device endocarditis. I'm not going to touch much on the device endocarditis for this case here. So just going to go quickly through this. So if you just look at the valvular endocarditis column here, so mostly a young population, almost 80% had a history of substance use who underwent percutaneous mechanical aspiration. The tricuspid valve mostly involved, and most of them had no tricuspid valve regurgitation prior to the procedure, but almost 1/3 did. And then the vegetation size was a mean of 2.4, so large vegetations. Staph aureus, the most commonly implicated pathogen, not a surprise here. And then, this isn't really a procedure that has been studied well enough that it's incorporated into the guidelines in a robust manner. Some of the most updated European guidelines did recommend using percutaneous mechanical aspiration for right-sided endocarditis if patients couldn't undergo conventional surgery, but that is only based on case report data. So we wanted to look and see how many of these patients who underwent percutaneous mechanical aspiration had a guideline-based interventional indication and what that guideline-based interventional indication was. And so for valvular endocarditis here, you'll see persistent bacteremia, vegetation size, septic emboli were common causes here. And then the preference for use. So why did people choose to do percutaneous mechanical aspiration instead of conventional surgery, which is, guideline indicated? And you'll see here that most of the reports didn't really specify, so we couldn't really draw conclusions on this. But for those who did report it, they said that people were too critically ill to go to surgery, so they thought that their acute surgical outcomes would be poor. And then some reported that there was high risk for recurrent endocarditis because of the ongoing injection drug use. But generally, I think that this variable that we were looking to understand was just underreported, and so we can't really draw much conclusion. Anecdotally, from the data that we have at Duke, a lot of these patients who do undergo percutaneous mechanical aspiration do it because they have a high risk for recurrent endocarditis because of injection drug use. And then in terms of understanding the outcomes of percutaneous mechanical aspiration, so like I said, there were very few cohort studies where we could really, see comparative analyses being done. But one thing you could imagine was that a suction cannula is being advanced and suction is applied onto a vegetation that's attached to a valve. And so you could imagine that there might be some valvular damage that happens during the procedure that could result in worsening of valve function compared to the pre-procedural valve function. And so we saw that around 10% of people had worsening of pre-procedural tricuspid valve regurgitation after they did the procedure. The big caveat here is that 85% of these reports or patients didn't have a post-procedural echo that was reported. And so this might be an underreporting of that. Mostly there were no other procedural complications and few patients required to get valve surgery post-percutaneous mechanical aspiration. So what do we know about this based on this? So far, it seems like PMA is being used for patients who have indications for surgical intervention but are deemed poor surgical candidates. We have inconsistent reporting of clinically relevant outcomes, so it's hard for us to make clear conclusions about the outcomes of percutaneous mechanical aspiration compared to conventional surgery. So we need more consistent reporting and we need more high-quality studies to better inform the use. So going back to our case, we had a multidisciplinary discussion with the cardiothoracic surgeons and decided that she would undergo percutaneous mechanical aspiration. So she underwent the procedure. It was successful. She had no post-procedural complications. Blood cultures cleared shortly after the procedure. And then a repeat transthoracic echo showed moderate tricuspid regurgitation. So it wasn't worsening from her pre-procedural regurgitation. And then she was planned for 6 weeks of treatment post-procedure and clearance of blood cultures. So how do you plan for the discharge of a patient like this? So 3 main questions come up here is IV versus oral antibiotic therapy in the outpatient setting. The use of long half-life lipoglycopeptides, so dalbavancin, and then multidisciplinary engagement for substance use treatment, addressing the underlying cause here. So I will touch briefly on each one of these 3, but before we get, I'd like to hear some quick thoughts from the panel about discharge planning for patients with injection drug use endocarditis.
Thanks, Dr. Murad. I'd be very interested to learn from our Chinese colleagues how they would manage this case in their practice.
So if I the one to treat the patient, I will utilize datomycin with full dose. Well, for the PMA and also for the interventional aspiration of the vegetation, because in China we don't have the experience, but my only concern is that because after detachment, maybe we may cause the PE. And if we're not able to aspirate all the emboli out, we may cause PE or secondary infection. Or if the surgery fails, maybe we need to have the emergent surgery for the tricuspid valve replacement. So I have a question. And after surgery, during the hospital stay, do you utilize vancomycin or do you switch to other antibiotics during the hospital stay after the surgery?
So for most patients, we've been doing vancomycin. Recently, there was a large interruption in our supply chain for IV fluids because of there was a hurricane that affected Western North Carolina where a lot of the IV fluids are made. And so there was an IV fluid shortage that prevented us from using vancomycin as much as we usually, or as much as we were used to. And so we had to switch to using daptomycin a little more. So that's a more recent development. But outside of this, I think we would have kept this patient on vancomycin while they're inpatient for additional cost concerns as well. I don't know, Dr. Holland, Dr. Fowler, what's your experience?
Tom, what would you do? You had a study that probably is relevant to this patient.
Yeah, I mean, we, the sort of like the case that I presented before, I think either vancomycin or daptomycin are reasonable antibiotic options early on in the hospital course. We've moved away from, early in my training or in my career 20 years ago, a patient like this with injection drug use would have had to remain in the hospital for the entire treatment course. Would have stayed in the hospital and received probably vancomycin for 6 weeks. we've increasingly are tried to develop other treatment options for these patients who inject drugs. Some of them will be able to leave the hospital with a PICC line as long as we feel like they have stable housing, and we'll be able to administer the antibiotic. Yeah, but I think, as Dr. Murad is probably going to talk about, we've become increasingly interested in the long half-life glycopeptide called dalbavancin as a treatment option that doesn't require long-term intravenous access. So this is a patient where I would be thinking about using dalbavancin once the surgery is done.
All right, I'm just gonna cover these slides here. So just go.
让我说一点去吧。这病人的话，就说让我去的话，可能是更早点换成打。
If I'm the one to treat the patient, I would also initiate datomycin in early phases, because for datomycin, especially for MASA, it is more potent than vancomycin. I also treat some endocarditis patients for prosthesis, implantation patients. So in less than 3 weeks, I'm able to clear the infection. The patient has utilized the drug for 6 weeks. So maybe IV, so will not be the appropriate one. And so because it is also less convenient for the patient to come back to the hospital to receive the IV injection, because we already removed the vegetation. The oral antibiotic can also work. So maybe for the cooldown drugs, and if there's appropriate drug based on the stability test result, oral ones can also work. And also for the cotrimoxazola, I think it can also work. But for the drug user with the endocarditis, maybe this drug may not work.
Thank you. Let me move to my next slide here. So addressing the first question, oral versus IV therapy. So we recently published a systematic review and meta-analysis of oral versus IV antibiotic therapy for staph bacteremia or endocarditis. And we did a systematic review and meta-analysis specifically of randomized control trials. So we had pretty strict definitions for what we would include. We needed the studies to be randomized controlled trials. They have to include and report outcomes for participants with Staph aureus bacteremia or endocarditis, and a intervention group that received oral antibiotic therapy and a control group that received IV antibiotic therapy, what would be standard of care in the control group. And so based on our search, we had over 8,000 that we first identified, and ultimately we're only left with 4 randomized control trials that we included in our analysis. So these will probably be familiar studies to you. The Heldman study from 1996, the Schrenzo study from 2004, Iverson study from 2019, better known as the POET trial, and then the Cash study from 2024, better known as the Sabato study for uncomplicated staph bacteremia. So meta-analysis of these studies, PO versus IV in terms of treatment failure, we didn't find any difference. The random effects model had a relative risk of 0.99 with a fairly narrow confidence interval. And then for adverse events, confidence interval was a little wider, but we didn't identify any differences in adverse events there. We were expecting that maybe patients who got IV therapy would have more adverse events. And so just for the sake of time, I'm not going to comment more on that, but few studies met criteria for inclusion in our analysis. And it seemed like for a select group of patients that were in this RCT, oral therapy was likely effective and safe. But there are some caveats here. So there is variability in the disease states that were included in these studies. So you had people in the different studies that had uncomplicated bacteremia, complicated bacteremia, right-sided or left-sided endocarditis, which are very different states. Relevant to our case, injection drug use was often excluded and underrepresented in these studies, and so it's hard for us to make clear conclusions about this population. And then the trial procedures that were done may not reflect real life management. And this is specific to frequent follow-up, frequent lab monitoring, and even therapeutic drug monitoring for some medications that we wouldn't typically monitor as standard of care. And so there are some caveats here. We don't think that this is generalizable to all comers with Staph aureus bacteremia. It has to be a very select group of patients that would be able to get oral therapy and have it be done effective and safely. And in terms of the, I'm going to speed up here a little bit. In terms of the long half-life lipoglycopeptides, dalbavancin was mentioned. So dalbavancin is a drug that can be given in 2 IV doses 1 week apart and can provide therapeutic levels up to 6 weeks. And so it allows patients to be treated without the need for long-term IV access. The DOTS trial, which Dr. Holland and Dr. Fowler conducted, just concluded, and we're expecting the results soon. The preliminary results were presented at ECMID and at ID Week this year. All right, I'm just going to skip to the preliminary results. So basically, in terms of comparing the DOTS trial to standard of care, comparing dalbavancin to standard of care, the DOTS trial didn't find that it was superior by desirability of outcomes ranking, which means that weighing both effectiveness, efficacy, and safety in a ordinal outcome, it wasn't superior, but it did meet pre-specified non-inferiority for clinical efficacy. So there was essentially no difference between dalbavancin and standard of care in terms of pre-specified non-inferiority for clinical efficacy. So maybe the last point we can touch on here is how should we be using dalbavancin? So should we be using dalbavancin earlier in the treatment course? Should we be using it once we're ready for discharge? Should we be using it only if there's 2 weeks left in the treatment course? So I think the strategy of how we use dalbavancin is going to be important here. So maybe Dr. Holland, since you were involved with the DOTS trial, you could give us your thoughts, and then we can get the thoughts of the panel as well.
Yeah, thanks, Ahmad. This is an antibiotic that is attractive in this situation. The patient who has an injection drug use where we're worried about outcomes. The way we used it in the DOTS trial and the way I use it clinically as well is that I employ it at that point where the patient has cleared bacteremia, has had whatever surgery or other source control procedures they need to have, and is doing well. And at that point, you're asking yourself as the provider, how do I finish this treatment course? I don't think I should stop antibiotics, after only a few days. I think this patient needs 6 weeks or 8 weeks of antibiotic therapy in total, and they're doing well. That's the point at which I would use dalbavancin and take advantage of that long half-life as a way to provide therapeutic drug levels over weeks without having a PICC line. We don't have any data for using it up front. Maybe it would work. Probably it would earlier in the bacteremia course. The main limitation there is cost. So for us in the United States, this drug costs several $1,000s per dose compared to vancomycin or daptomycin, which are much less expensive. So that's one of the limiting factors for using it more.
May I have a question? 如果说这个病人能够
If the patient can be discharged early, like 2 to 3 weeks earlier, then maybe using dalbavancin can save more money because hospitalization may be more costly.
Yes, that is exactly right. And so that really is the argument or the appeal of that antibiotic, is that exactly as you said, it allows the patient to leave the hospital safely sooner and saves those costs of hospitalization.
All right. And then addressing the underlying cause here, so substance use disorder care. So we're learning more and more about this over the past couple of years, but it does seem like there is insufficient and inconsistent treatment of the underlying substance use disorder among patients who are admitted with substance use associated infections like bacteremia and endocarditis. We also know from some literature that patients with injection drug use who get Staph aureus bacteremia or endocarditis can have worse outcomes, worse mortality, more persistence of infection, and higher rates of readmission. And so over the years now, specifically in the United States and in our institution, we've come to really appreciate the value of a multidisciplinary addiction medicine team. There's some literature that's showed that addiction medicine consultations increases rates of initiation of treatment for addiction, increases likelihood of patients completing their antibiotic therapy, and results in fewer self-directed discharges or discharges against medical advice. And so we have a team here at Duke called the COMET team, caring for patients with opioid misuse through evidence-based treatment. And they're a multidisciplinary team of incredible hospitalists who do great work. They will evaluate patients for addiction treatment, and they will also help us make an evaluation of whether the patient is safe to receive a PICC line and undergo outpatient IV antibiotic therapy. They evaluate things like stable housing, whether they're going to be compliant with treatment, and their history as well. So ultimately, we were able to utilize our colleagues here. They initiated addiction treatment for this patient during hospitalization. The patient did well. She had stable housing. She had a good support system that they were able to utilize, leading to her discharge. And so ultimately, she was discharged to complete a 6-week course of outpatient IV antibiotic therapy where she got a PICC line and completed her course, and she did well. These are my references. Take any additional questions.
I
have a question.
Question.
邱老师，
你说
OK， Professor Mora, thanks for your excellent presentation. And I'm an intensivist from cardiovascular surgery department. So I'm very interested in your PMA technique. My question is, during the PMA procedure, how about the incidence of pulmonary embolism and tricuspid valve damage? The second question is, in China, the endocarditis is not same as in USA, often occurs in the left side part of the heart. So can we use the PM techniques in this kind of patients through the atrial septum? Do you have some experience? And the third question is, after PMA, can we shorten the duration of antibiotics if a patient without prolonged bacteremia or drug abuse? Thank you.
Okay. I love all three of these questions. So for the pulmonary embolism, so in our review of the literature, post-procedural complications were rarely reported. Among those that were reported, there weren't any pulmonary emboli that were reported. We are conducting a large national registry of patients who undergo PMA. So we have multiple institutions that are contributing patients, and I think right now we have around 300 patients in this registry where we're trying to understand things like the rates of post-procedural pulmonary emboli or post-procedural need for emergent valve surgery after PMA. And so that data is still pending. In the scoping review that we did, we didn't see any pulmonary emboli. In that scoping review, we did find that around 10% of patients did have worsening valve function after getting PMA. But again, that was mostly underreported, and so it might be larger than that. We have some preliminary data from Duke, and it looks like maybe around a quarter of patients have worsening valve function after PMA. So that's a consideration. And then
let's see, there was a left-sided.
There was left-sided. Yes. So for our scoping review, we excluded the left-sided cases, but there were 2 cases that we found. There's probably more now where they did exactly what you said, where they went through the septum into the left side to aspirate mitral vegetations or aortic vegetations. Those cases, I believe they utilized devices to prevent emboli to the brain and cause strokes. At least one of those cases, if I recall correctly, the patient was on extracorporeal mechanical, so was on ECMO while this case was being performed via ECMO. And so it is a little more complex. At Duke, we don't perform, the CT surgeons do not perform left-sided percutaneous mechanical aspiration, just do right-sided. And I think there is more literature and case reports about right-sided endocarditis. So certainly an area that can be explored more. And then for duration, that is a really good question. And I think the answer to that is we don't know. And so I think for now, we treat patients for 6 weeks after they get the procedure and clear their cultures if they have no other sources of infection. And we don't know if shorter treatment durations would be appropriate in these patients. And so I think we do need to build a more robust retrospective cohort and then use that to inform prospective studies to try and decide on treatment duration.
Okay. 还有别的问题吗 ？Any question？ 还有吗
Any other questions?
Dr. Murad, it sounds like what you need is a randomized controlled trial. What are your thoughts about that?
Yeah. So yeah, I agree. I think we do need a randomized control trial. So Dr. Holland and I, along with our other colleagues, we just published an editorial last year proposing a clinical trial for something like this, specifically for right-sided endocarditis, where it would be an approach that would almost mimic exactly what we see in clinical practice right now, which is patients get evaluated for conventional surgical valve repair or replacement, and then if they're not candidates, we randomize them to either getting medical therapy alone or getting percutaneous mechanical aspiration followed by medical therapy. So hopefully in the next couple of years, we'll have some more momentum to conduct a clinical trial like this.
I believe it's indeed we need an RCT to really validate or prove PMA is definitely better than antibiotics alone. Any other questions or comments?
I agree.
谢谢。好，还有问题吗？大家？
Any other comments or questions? If no, then actually we are slightly over time. I would like to once again thank Professor Murad for your case presentation. Thank you everyone for joining the discussion. And I would like to hand over to Professor Peng Zhiyong from Critical Care Medicine of Zhongnan Hospital. Professor Peng, you have the floor.
Hello, everyone. I'm happy to be the moderator for this section. In this section, we have one case from China. And then after the case, and we will discuss about the case. 好，那么我们开始就讲，我们就把第一个 case， 把第一个那个
Okay, so I would like to invite the speaker of this session, Professor Qin Xiaohua. Professor Qin is from Antibiotic Institute of Huashan Hospital of Fudan University. She also held a lot of important academic titles. I'm now going to read one by one. Over to you, Professor Qin.
Hello, everyone. It's my honor this 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 night or this evening, maybe in USA. 因为时间的关系，我们就直接
For
从病
the interest of the time, we will start from the medical history part.
Sorry.
全屏一下呀。
Full screen, please.
Yeah. 那么我介绍的这个病例呢是
So we are not seeing your slides.
Screen share 没有共享，刚才共享到了。
但是刚刚也没有用播放模式的，
好，这
要
个可以
播放模式的。
播放。
You need to play your slides.
OK，好了。
现在看到啊，
OK
Okay, so I think right now you can see my slides.
我们这个病例呢是一个60
So
岁的
this patient
身高
is male,
173体重75公斤
and the patient is 173 centimeters with a body weight of 75 kilograms. The patient developed a fever, generalized weakness, muscle soreness. The patient only had a medical history of hypertension, and the patient would take a small volume of alcohol on a daily basis. And actually, on 3rd of May, and it was during the Lip Festival, the patient had dinner with several friends, and the patient took a lot of alcohol, so the patient developed a fever. Originally, the patient thought it was a cold, and then the fever peaked to 38.8 South centigrades, and then the patient had weakness of lower limbs and unable to work, and the patient admitted to local hospital infection department. So at that hospital, the patient was prescribed with ceftriaxone with linezolid. However, the patient got worse and worse. And also on 8th of May, the patient had confusion, palpitation, chest distress, and dyspnea. The patient was administered to local ICU. And on 10th May, the patient has been transferred to my hospital. So this is the local hospital auxiliary examination. So we can see elevation of the WBC and neutrophils. CRP was also elevated. ProBNP was mildly elevated. And so for the cranial CT, there was no abnormality. On the first day, and when the patient had poor awareness, the patient did another cranial MRI and indicating acute cerebral infection, as well as intracranial bleeding. And so on the 9th of May, the CT image was also aligned with the original MR result. The patient also had hemorrhage in the subauricular face. And so we can see on the 7th, the patient was administered to the hospital. 2 days later, the blood culture was positive for Staphylococcus aureus, and the patient is MSSA. And why the patient was transferred to our hospital? Because at that local hospital, the physician was able to associate intracranial hemorrhage with the infection. Back then, we considered the patient would have IE because of the MSSA result, as well as the multiple intracranial infarcts, and the local hospital transferred the patient to our hospital. Upon admission, the patient had mild fever with very quick breathing frequency, and the patient was able to answer the questions, even though the patient was in poor status. And also at the end of the finger, maybe the picture is not very clear. We see multiple hemorrhages and ecchymosis. And also we see the ecchymosis scattered on the tips of the big toes. And so we can see this is the blood test result, and we can see inflammation markers are all elevated. At the same time, the patient also had the EGFR standing less than 50 with impaired kidney function. And also for D-dimer, the patient had also elevation of it. And so we can see the cardiac ultrasound result, and we considered about the vegetation on the aortic valve, and we see the patient had hypertension in pulmonary artery. And so back then, we were suspicious of the pulmonary embolization. So the first question is that the patient only took alcohol. There is no obvious wound. Why the patient would have the MSSA infection? What is the source of the infection? And the patient also had a neurological manifestation. So for the bacteremia of the Staphylococcus aureus, do we have other associated infiltrative lesions? And also for the pathogen, whether the patient had other virus infection that caused the fever. And so back then we had a lot of questions in the mind. For MSSA, where does it come from? Why in just 1 week time, the patient had severe suspicious IE with the vegetation? Maybe the patient already had a virus infection in the past. And also for dissemination parts, in addition to the bloodstream, for the lung and the images studies also indicate infection. And according to the original hospital image report, the extravasation of bilateral lungs were also identified. Another important part is the brain and whether the intracranial hemorrhage is confined to the intracranial lesion or whether they are related with the detachment of the bacterial thrombus. And also, the patient had a very quick breathing frequency, and so whether the patient is cardiogenic for those for the heart failure, or the patient that had concomitant pulmonary embolization or has the atelectasis issues. So our original consideration for the diagnosis was the MSSA bacteremia. And so the IE diagnosis was quite clear, even though we only had a one positive blood culture, the vegetation was not confirmed, and the patient had pulmonary infection with intracranial hemorrhage. The most important information is that the patient had renal impairment, and the patient also had some positive medical history. So for MSSA, we do have clear evidence to support that according to the paper and related publication. So the patient had onset on the 3rd of May, and then the patient had vegetation within 1 week. The patient should have the acute IE, which is also indicative of the infection of Staphylococcus aureus. And we also checked the patient skin thoroughly. There's no wound. And so maybe the patient took alcohol and maybe the bacteria enter into bloodstream from the GI tract because the patient was kind of immune compromised because of the alcohol intake. The patient also had neurological complication. This is also quite common in the Staphylococcus bacteremia. And for the interest of time, I'll skip this part. So at the first phase, we come to the stage to treat the endocarditis. According to the publications, if the MSSA is from the GI tract, actually cephalosporins will be the preferred one, such as the cephalotrexone. And actually, according to the guideline, if it is MSSA infection, and so we should utilize the oxacillin and as well as the cefazolin. And the patient may have the infection source from the GI tract, and the patient may also have the nausea vomiting. So back then, we were suspicious of the GI tract infection as the main infection source. And so we have chosen the cephalosporin for this patient, and based on the IE indication, and we need to also do combination with full treatment course. So back then, based on the prior slide, because the patient already have intracranial lesion, and this is also associated with the MSSA and the carditis. And so maybe intracranially, the patient also had an infection. So when we choose the drug, we also need to choose the drug that is able to penetrate BBB, and also need to use the drug at the full dose. At the very beginning, we set out the plan for the choice of the ceftriaxone 2 gram Q 12 hours with fosfomycin 4 gram Q 12 hours. And because the EGFR for this patient was less than 50, that's why we have chosen the two drugs in combination. For ceftriaxone, and the main consideration is to treat MSSA. And so we were suspicious of the GI tract as the main infection source. And so this may caused by the inadequate clearance of the gram-negative bacteria. So fosfomycin is the one to kill that bacteria, and also for ceftriaxone, we don't need to adjust the dose for kidney impaired, function impaired patient. For fosfomycin, for the MRSA or MSSA infection, and for beta-lactam, and the quiloton drugs, when we compare against those drugs, it can have very good synergistic role, and also it can have high concentration in the extremities. It is able to penetrate the BBB, so it can also be metabolized through the kidney. Therefore, for patients that have the impaired kidney function, we need to reduce the dose. So at this stage, I also want to listen to our distinguished experts' opinion, especially our international guests. So for IE patients with intracranial lesions, what would you use to treat the patient at the initial phase? Thank you. Thank you very much for your wonderful case sharing. This is indeed a very representative case. And so the patient had MSSA infection and also has intracranial infection lesions. So any comments from our audience? So I have a question for you. Just like you mentioned, and we need to prefer beta-lactam. Why don't you utilize penicillin? Why you choose cephalosporin in combination with fosfomycin? Why don't you utilize penicillin? Well, for this patient, and the patient had a positive test of the penicillin allergy. So, and because of the nursing team, they kind of are under pressure for utilizing penicillin. So that's why we have chosen cephalosporin with fosfomycin. So for the interest of time, I will continue with my slides. So after we set out this initial treatment plan and we identified the vegetation on the day of admitting to the ICU, we also did a cardiac ultrasound for this patient. Back then, we considered to exclude the pulmonary embolization because the patient had hypoxemia and because the patient had pulmonary hypertension during the baseline. So we did the cardiac echo for this patient. And so we see enlargement of the ascending aorta And even though it is not as large as the baseline one, originally it was 60 millimeter, and pulmonary hypertension also improved. And for the lower limb ultrasound identified no abnormality, so we exclude the PE basically, but the vegetation is very obvious. In addition to the left coronary valve vegetation, we identified the two other vegetations in the right coronary valve, and we also see a perforation in the right side. So I think the diagnosis of IE is confirmed.
Here, these are the intracranial lesions. So here we'll be able to see a spotty high density shadows in the right frontal lobe, and patchy high and low mixed density shadows were observed in the left frontal lobe. And also, according to lung CT, upon admission to ICU, the patient only had the atelectasis and bilateral pleural effusion. And gradually, during the treatment process, we still see MSSA for this patient, MSSA persistently positive according to the blood culture result. Later, I will show the drug sensitivity result in the next slide. And also here we can see the creatinine continue to rise. NT-proBNP has increased from 1,000 to more than 10,000. So after admission, blood culture demonstrated MSSA. So here we can see after using the ceftriaxone and fosfomycin, the temperature had a trend of reduction. However, the patient had another very important issue, which is heart failure. So we had some reflection about the use of fosfomycin because in China, we only have the fosfomycin sodium. So 1 gram of fosfomycin sodium will contain 0.3 gram of sodium. And that might increase sodium ion in the blood circulation and increasing circulating blood volume, increase cardiac load. So we have made some changes to the anti-infection regimen. We have changed that to ceftriaxone and daptomycin. Daptomycin is very good for Staph aureus, and it can penetrate the biofilm, and it has very unique antibacterial mechanism, like mentioned by Professor Wang. It has strongest killing effect against Staph aureus. So we use daptomycin to replace fosfomycin. And daptomycin, choose daptomycin, we have another consideration about the dose of daptomycin for patients with impaired renal function. Previously, we used 4 to 6 milligram per kilogram of body weight. The patient's body weight is 75 kilogram. So we started with 6 milligram per kilogram of body weight. And here we can see that comparing to fosfomycin, NT-proBNP showed significant reduction after switching to daptomycin, and the body temperature further reduced as well. In ICU, the patient has been in ICU for a week, so our ICU doctors, they're very worried about the temperature fluctuation. And also from the sputum test, we have E. coli positive results. So maybe we need to consider gram-negative infection. So we would like to hear from our intensivist today. For this patient, under these circumstances, the patient had repeated low-grade fever. After switching to ceftriaxone and daptomycin, the patient had recurrent low fever, and also we have the MAC aging positive, and also the patient test positive for E. coli. So for this case, what will you do? Will you enhance the anti-gram-negative infection control, or what would you do? What about the blood dynamics, Professor Qin? Well, at this stage, the blood dynamics was okay. So Basically, at that stage, the patient haven't started CRRT. Blood pressure is in between 80, 130. So it was stable. And then about respiratory function, about the airway, did the respiratory function worsen? No. Back then, there's no obvious or significant worsening of respiratory function, and consciousness actually has improved. Personally, I think we should wait. Thank you, Professor Pan, for your comment. That was also what we did. So when we monitor the patient WBC and PCT, we can see WBC and PCT have some increase. We measure WBC every day and see some increase of white blood cell count. So the ICU doctors decided to make some changes. So we have changed the ceftriaxone into another cephalosporin. We changed to cefepime. So we've decided to use the cefepime and also daptomycin. However, after changing ceftriaxone to cefepime, the patient's body temperature started to rise, and also the patient had worsening dyspnea, and urine output markedly decreased. The kidney function, the respiratory function worsened, so the patient had trachea intubation and mechanical ventilation. The patient also had heart failure on 22nd of May and had anuria. So we had fluid restriction and daily CVV HDF. And also we can see for the patient's vegetation, the vegetation start to flame. So basically, the patient situation get worsened, and from pulmonary CT, here we can see very diffusive infection. And on 21st of May, the patient may have acute pulmonary edema. And here we can see, according to the pulmonary CT on 23rd of May, we'll be able to see some central edema and solidification. And we believe heart failure is the major reason, because this is the patient we managed together with the ICU specialist. So we believe heart failure is a very important factor for the patient's circumstances. But of course, we have evidence for inflammatory markers, and we can see the infection is getting worse. So should we focus on MSSA positivity, the IE control, or maybe we should consider the gram-negative infection, the combined pulmonary infection? So for this patient, we have performed the sputum etiology test. And also for this patient, we have actually added meropenem. We've added meropenem, and for daptomycin, considering the patient had heart failure and worsening of heart failure, and maybe the worsening of heart failure is because the underlying disease is not very well controlled. So maybe we should enhance the anti-infection treatment for gram-positive bacteria. The patient later received CRRT. So with CRRT, maybe daptomycin will be cleared very rapidly, and maybe with CRRT, daptomycin dose is not enough, not sufficient. So basically, for patients with CRRT, according to literature, daptomycin should be administered every 48 hours to achieve better PK/PD. And also for patients with bloodstream infection, the recommended daptomycin dose should be 8 to 10 milligram per kilogram. We have checked the massa bacteremia guideline and found a guideline. Daptomycin dose, recommended dose is much higher. Of course, they did not consider the kidney function when recommending this 8 to 10 milligram per day per kilogram of daptomycin dose. But of course, this recommendation is for patients without renal function damage and without CRRT. Considering patient circumstances, we have adjusted the dose of daptomycin for this patient. We have added 750 milligram of daptomycin per 48 hours. So we have adjusted the daptomycin dose for IE. And of course, if it's MSSA, meropenem should work for MSSA. And here, as we can see, the CK and myoglobin show significant increase. So considering this as a patient with heart failure and also valvular damage, maybe there are some myocardial damage. And we have checked the troponin T and CKMB. We can see TNT show no obvious increase. However, CKMB shows some increase. So we believe CKMB increases not because of the cardiac diseases. So we consider maybe that's an adverse reaction of daptomycin, because for daptomycin, one of the main adverse reactions of daptomycin are myopathy and rhabdomyolysis. The CPK elevation may happen for patients who receive daptomycin. So for these patients, we need to avoid the use of statins and fibrates. So CKMB increase, we believe, is due to adverse reaction to daptomycin. So for this patient, daptomycin is no longer an appropriate choice, because for rhabdomyolysis will result in higher pressure on the kidney function. So is there a better option? We focus on linezolid. Some may ask, why don't you choose vancomycin? Because the patient, we have considered patient kidney function, creatinine level, and the patient is already receiving CRRT. So vancomycin, we think maybe we can save vancomycin later. Maybe we can try linezolid. Even though we know for patients with MRSA or Staph aureus, even though it's MSSA, linezolid for Staph aureus, it's not recommended to be the first choice of IE due to MRS, unless as a salvage treatment of persistent MRS bacteremia. And according to this literature, basically has mentioned that we need to avoid cases who combined with IE. And for patients with right side infective endocarditis combined with infective pulmonary emboli and pulmonary abscess, it's recommended to use daptomycin and linezolid. And also for CNS infection, linezolid is also recommended as a backup plan. And also we can use IV TMP SMZ. But so far in China, we don't really have TMP SMZ, or the ones that we have in China is way too expensive. So we don't consider TMP SMZ. So we have tried linezolid for this patient. So we can see after we have increased the dose of daptomycin, the patient's body temperature had a trend of reduction, and then we switched to linezolid. We did not have very high hopes of linezolid. Here we can see after switching to linezolid, the body temperature start to increase immediately. So for this patient, we were considering whether we should start vancomycin. This is the myoglobin. After we have discontinued daptomycin, there's significant reduction of myoglobin after discontinuation of daptomycin. And then from the sputum result, we can see we have 3 results. We have KPC positive from sputum result. That was from day 1. And then for the following 2 days, we can see we have CRPA positive, and also the patient is sensitive to the avibactam. And we have another sputum test result. The patient had CRKP. In the ICU, Indeed, we have a lot of resistant bacteria, and when the patient been in the ICU for 2 weeks with intubation, indeed, there's a risk of resistant gram-negative infection. So, for this patient, the patient had a rebound of body temperature. Maybe that's because of the resistant pulmonary infection. So, for this patient, we have decided to make some further change. And here we can see that with the ceftazidime, avibactam, and linezolid, the patient body temperature start to reduce. And also we can see for the patient's PCT and CRP, there are some reduction trend, even though some fluctuation.
So we feel a little bit relieved, and so we thought that the ceftazidime and avibactam was able to clear the gram-negative bacteria, and also for the IE, it was also under local control. We didn't see relapse of the fever, and also for the chest CT, we can see it has greatly improved compared with the prior situation. However, when we feel a little bit relieved at that time, we still identify the relapse of the fever later. And even though the patient was in CRRT on a daily basis, and so the nursing team say that they are actually working OT. And so at the midnight, when the patient had a long CRRT, the patient would have heart failure with unstable hemodynamics. So at this time, we know that for the IE at this stage, for internal medicine team, we tried everything we can. So, sorry. So at this time, we do kind of run out all the choices we have. And also for the linezolid, the volume of injection is 130, and maybe we can change that to tablet. And also just now, the prior speaker shared with us about clinical trials comparing IV with oral drugs. We also searched some paper and seeing this is feasible. And the second thing is that because the fever kind of came back, and so maybe with the single drug of linezolid, it may not fully control the IE, so maybe we still need to add on the cephalosporin. And so we also checked a lot of papers. So for the interest of the time, I will skip that part. I draw the similar conclusion with the prior speaker. Actually, in this study, for the oral drugs, they are inferior to the IV ones in terms of the AE, the efficacy. Actually, in terms of the efficacy, they're comparable. In terms of the AE, oral ones have less AEs, and because at that time the patient didn't finish the treatment course, we switched the IV to the tablet formulation for linezolid, and so at that time the patient temperature was maintained within 37.2. And also for inflammation biomarkers or the markers, and they rebound. And after that, we also add back the cephalosporin, and then they decrease again. And so for the internal medicine team, we basically round all the choices. And the blood pressure was not able to be maintained. So we did the CRRT with the vasopressors on a daily basis. So at this time, how can we correct the repeated heart failure? That's why we brought in the surgeons. And actually, before that period, we already had weekly discussions with surgeon because back then the patient already had cardiogenic shock as well as the pulmonary edema. And the patient also had the indication for delaying surgery, namely intracranial stroke. Even though in Huashan Hospital, we're also famous for neurosurgery, but the cardiac surgeon was still concerned about the intracranial hemorrhage. So we tried to delay the time for the surgery, and the patient's family member were also agreeing with our idea. So finally, in week 6, so you can see it is 13th of June. It is 6 weeks into the hospital. And so the surgeon thought the acute phase of intracranial hemorrhage already passed. So the patient received open thoracic surgery for probing. And so you can see we had the perforated aortic valve. And so second picture was the resected vegetation. For the vegetation with the next generation sequencing, indicating the Staph aureus. And because we already had the patient on a lot antibiotics for a long period of time, so the culture result was negative. And actually, after the surgery, the patient had a lot improvement of the cardiac function, even though the patient was still on daily CRRT, but the duration was shortened as we maintained the original protocol. Secondly, after the surgery, we began to waive the ventilator and the patient began to recover for the consciousness. And from the eye contact of this patient, we can see the improvement of the consciousness of the patient. So after that, the patient was in very smooth recovery with constant decrease of the inflammation markers, with also very stable body temperature. So in 2 months, after 2 months of hospitalization, the patient was discharged to another rehabilitation hospital, and during the follow-up for the cranial CT images, we can see the original hemorrhages disappeared. And so in October, 2 months after the surgery, we did another phone follow-up, and the patient checked kidney function at the local hospital, which recovered proBNP, decreased to around 319. And the patient also recorded a video for us. The patient was able to walk at home, and he is even able to say hello to us. So I think this is indeed a profound achievement for all of us, because for the IE infected with the Staphylococcus aureus, it is quite difficult to treat. The patient also had many special conditions. And so we considered that for the medical choice. And ultimately, we got the success. And so we changed Lesolite to another drug to control the heart failure. And also for the surgical indication, we also have good management of it, because in early phases, the patient had a heart failure without good control of the infection. Originally, the patient was indicated for surgery, but we still had the right timing for the surgery at the delayed phase. So I think this is a great success for both of us. Thank you. Thank you, Professor Qin, for your wonderful case sharing. So I think now I will invite the panelists to give us comments.
Case with the endocarditis induced by the bacterial meal, original with the MSSA, and also transferred to the neurology infection, cerebral hematoma, a lot of problems, and initially with the antibiotic treatment, and also complicated with the ventilator-induced pneumonia, and heart failure still persistent. Last, the patient received the surgical operation with the valve replacement, and then finally recovered totally. So, but it's very complicated, very difficult case. So, any questions, any comment for this case?
I'll make a comment. This is Vance Fowler. I think the first thing to point out is that medicine is messy. Many things happening, confusion, uncertainty, and a number of questions in this very complicated case that the critical care physicians had to manage in an excellent way. Of course, we all would like to have had the surgery sooner, but it wasn't possible because of the CNS process. The optimal choice of the antibiotics, which one to use and how and where. It's very likely that in the United States, we may have chosen different antibiotics. But one thing that's very interesting is the fact that there is more than one way to do the right thing, oftentimes. I think that's especially true for Staph aureus bacteremia. There was a recent study that we performed with Annette Westkies from the Netherlands, where we surveyed over 2,000 providers, ID physicians throughout the world, including China. I think China had the second largest number of providers looking at different management questions. And the conclusion of that study, which was published in Clinical Infectious Diseases in 2023, was that there was really no standard of care internationally because people in so many different regions of the world treat the same infection differently. So I think that for MSSA, there are different choices. We heard some of the choices today. So I, would probably have used a drug called nafcillin, an anti-staphylococcal penicillin like that. But again, there are multiple ways to do the right thing. Ultimately, this is I think an infection that required surgery. And when the surgery it was possible to perform the surgery for reasons of safety, there was a wonderful outcome. So thank you for this excellent presentation.
Thank you, Professor Vance.
Well, let's comment. So any further comments or questions?
Professor Qin, thank you very much for the complicated case. So for the initial antibiotics choice, I may have different opinion for MSSA. Actually, normally we would have a different cephalosporin choice. For penicillin, for adults, they have high resistance. And so for streptococcus, we may utilize ceftotraxone. Why would you choose ceftriaxone in the very beginning? And for nilotinib, I understand it is indicated for intracranial infection, for bloodstream infection. For staphylococcus, the patient had bloodstream infection. We may also consider it as primary infection. So maybe we will not recommend this in the first line. So what is your consideration for your first line choice? So I think, yes, we were kind of in a dilemma for making this choice for MSSA. And I understand first line choice would be the oxacillin, and for the penicillin allergic patients with first choice will be cefazolin. And I understand the patient was not able to identify the infection source. So we also were suspicious about the GI source infection. So we read a paper saying the GI tract source, the Staphylococcus aureus infection. We may prefer beta-lactam drug, and also for the ceftriaxone, it is not able to penetrate BBB. So the ceftriaxone is able to penetrate the BBB for nilosolide, because we kind of moved from datomycin for nilosolide. I understand it is not the preferred one for Staph aureus, and so only when we have persistent bloodstream infection without IE, it can be utilized as the salvage. But back then, because we didn't want to utilize vancomycin, so among all the choices, the patient in the past had MAC-A gene positivity, and even though the sample test result indicate MSSA, we also consider MR. So back then, we have chosen nilosolide for this patient, and because of the kidney function issue as well as the heart failure issue, we made this choice.
Very good case. I would like to ask about some basic situation of this case. At the very beginning, the MSSA, where is it from? From the skin, soft tissue, or does the patient have diabetes? No, the patient have no diabetes, only drinking history, no injury. So we think maybe after drinking, there might be some infection source from the GI tract. That was our assumption because according to the wife of the patient actually had some nausea, vomiting, aspiration history after drinking. We have checked the patient's skin. There is no wound, no injury, and we have checked the oral cavity, no problem as well. We thought maybe it might be the teeth and also a GI tract. Thank you. If it's from the GI tract, then it might be gram-negative. Gram-positive, it's very rare if it's from the GI tract. Thank you.
Any other comments?
Yeah, I'll make a comment. So it's very interesting. We're learning more about cefazolin and the penetration into the CNS. There was a recent article in Clinical Infectious Disease in 2023 that reviewed the literature about this, and seems like the traditional and classically that's how we practice as well, as we favor the anti-staphylococcal penicillins for CNS penetration compared to cefazolin. But it seems like we're learning more about this, and the authors of that study, they reviewed the literature, and it looked like if you got a 2-gram one-time dose of cefazolin compared to a 2-gram one-time dose of nafcillin, your CNS concentration of cefazolin was actually higher. The issue was with maintaining an area under the curve, an AUC concentration of cefazolin that would be sufficient for treatment. And so the traditional dosing of 1 to 2 grams Q8 hours may not be enough, but a dosing of 2 grams Q6 hours or a continuous infusion of cefazolin may actually be adequate for CNS coverage. And I can share the link to that article in the chat. It's a very, very interesting manuscript.
Thank you. I totally agree with your comment.
Yeah, thank you. Oh,
好的，还有
Thank you very much.
any further comment？ 还有没有其他的一些一些问题要问的？如果没有的话呢，那我们要总结了哈。
If no, then we are going to summarize and conclude today's meeting.
Time flies. It's almost done for today's session. So now I'd like to invite Professor Wang to have summary for today's symposium. Professor Wang, 王教授，
好嘞，
你总
祝
接听
各位
了。
现在喉咙不好，非常高兴，就是说和美国的
Today we are very happy to have this opportunity to discuss with our US colleagues about these very complicated, severe cases with conventional treatment. And also, we have tried some new innovative treatment for the third case. I think there are some the infection factors and non-infection factors, and also gram-positive and gram-negative infection involved. So it's a very complicated case and also very lengthy process. And today we have a very good discussion with the translation, and I believe this is a new way that we have tried. In other academic exchange meetings, we mostly just have lectures. We don't have discussion, that much of discussion. We hope that we can have different forms of exchange so that we can communicate with each other in a better way. And once again, I would like to thank all of our participants, including our 3 experts from United States. Thank you very much for being here, and thank you everyone for preparing the slides and preparing for this meeting. And also today, I'm very honored to co-moderate with Professor Cho and Professor Peng. And also, I'd like to thank the sponsor of today. I'd like to thank CR Sanjo for your academic support. Professor Cho, anything to add? No, I don't have anything to add. Maybe any final remarks? I don't have anything to add. I believe today we had very good discussion and also experience shared by our colleagues from Duke and also the case shared by Huashan. I think it's very unique and very special. We have all learned quite a lot. I really enjoyed the discussion today. And also today we've talked about left side IE, right side IE, and also intracranial infection, etc., and systemic infection. I would like to thank everyone for sharing these excellent cases, and also thank you for sharing different approaches of treatment. And I think it's very inspirational for patients with infection, how to manage our patients with infection. I believe we need not only new antibiotics, but also new imaging approach, and also how to manage the infection foci, new approaches of doing that. Thank you very much. Thank you. Do we need to invite our US colleagues to conclude or summarize the meeting? If no, then we will conclude the meeting, and this is I believe this is the end of tonight. Thank you very much for your participation. Thank you, everyone.